Difficulties as usual, everybody. Welcome to the VBF Month of Awareness Facebook Live. Today is a great day because it's not only our International Day of Awareness, but we have two of the leading women laser experts in the world with us today, and we've never had two on at the same time. So we have Dr. Kristen Kelly from UCI. How long have you been treating vascular birthmarks?
Almost 30 years. I think I'm just a few months shy of 30 years at this point, so quite a while.
That's amazing. And we have Lisa Arkin from the University of Wisconsin. And how about you, Lisa? Dr. Lisa Arkin, how long have you been treating?
A little less than 30 years, but I'm so lucky to have such remarkable mentorship from Dr. Kelly. So I finished my fellowship now 12 years ago. So about 12 years of the remarkable privilege to treat these patients and learn from them so we can get better treatments and move the field.
And they're going to have some great insight into just coming home from the ASLMS meeting, which is the International Laser Society for Vascular, for all medical laser devices. But they did a session on all things vascular birthmarks or all things red, whatever it was. And I was able to attend that and hear about their techniques and their protocols and how they approach vascular birthmarks, because just like no two birthmarks are alike, pretty much no two doctors treat vascular birthmarks alike. So I was very excited that they said yes, that they would do this live session. So I see a lot of people are joining us, and everybody, they're here. You only have them for now 57 minutes. So make sure you start putting your questions in. I know a lot of you are getting on now. Hi, Angie. Hi, Zen Chen. Hi, Sophie. Hi, Vagal. Hello, everybody. As soon as you log on, you can start asking questions. I'll start. Dr. Kelly, I heard a rumor that you now have the V-Beam Pro. Is that true?
We do have the V-Beam Pro. I'm super excited about using it. I've only had it for about a month, so I have to say I don't have extensive experience with it. Of course, I have extensive experience with some of the earlier versions of the V-Beam series, but we're liking it very much, and so far it has been great. Some of the things that are different about it, in case some people might want to know that, we can use large spot sizes. It's a little bit faster. Also, the energy, the intent is that the energy is delivered a little bit more evenly. And so the hope is that that will provide us better treatment success. And then it also has the option of post-cooling. And so with the post-cooling, our hope is that it might make it a little bit more comfortable. There's some very early studies. I think Paul Friedman did one showing that that may be the case, something that needs to be studied further.
Have you done any without general anesthesia, like, just with topical? And are they saying it's less painful to you?
Yeah, the vast majority of the treatments I do now are not with general anesthesia. I have a couple of patients we do under general anesthesia, but most I do not. And so I have had quite a number of patients that we've already treated, and several of them have said they think it's a little bit. Now, I haven't done a lot of the post-cooling yet because, again, we just started with the device, but overall, people are actually saying they think it's a little bit more comfortable. However, early days, and then there could be a little bit of a placebo effect. People know it's the new device, and so they may be hoping that it's got, some benefits to it. So we don't have a study yet, but that is one of the things we're going to be studying. Can we get less purpura but still get a really good result? And also, can we use the post-cooling and make it more comfortable? So those are all studies in the works.
So we have our first question already, and we have quite a few people on. So Ruth Dub wants to know, and I guess this would go to you, Dr. Kelly, because Dr. Arkin doesn't have the Pro yet. Is the Pro laser better at treating blebs compared to the Perfecta?
So I don't have like a study or anything to say, but I mean, it does have a long pulse 1064 in it that can be used for treating blebs. The question is, when you say, is it better? I don't know the answer to that. I am guessing that it probably is not going to be better. I think it might be the same. I mean, there are multiple ways that you can treat blebs. I'm sure that you guys are aware of this. You know, the 1064 nanometer device is one of those options. But honestly, sometimes I have patients where we just shave them and do a little cautery and then we laser over it. And honestly, for some patients, that works beautifully and may even be a little bit safer sometimes. The 1064 can be a very good device, but it's harder to see an endpoint, or really there's not a really good endpoint, and it's got less affinity for the venous blood that we see in port wine capillary malformations. So, you know, it is a riskier device, but there are times where it can beautifully treat nodules and things like that, but it's not the only way.
That's a great answer. I can answer, Maria, your question is, what is the actual name brand for the Pro product you're referring to? It's the Candela V-Beam Pro. It's just the next generation of their pulse dye laser. Jen G says, my son Aaron has been receiving laser treatment since he was born in 2011. Total, his port wine stain got faded about 20%. Is there a new therapy in the last couple of years? So he's only gotten 20% clearance and he's been getting laser treatment since 2011. But I guess you wouldn't know how to answer that. Maybe Dr. Arkin, you could take this because you don't know what device he's being treated with, but maybe
Yeah,
you can.
these are the cases where we're thinking, how can we change our parameters? How can we, alter the conception of the device? And then in the future, how can we think about an additional treatment option, whether it would be a cream or probably less likely a pill that would actually respond to some of the signaling that these genetic birthmarks do, and the adjuvant treatments where we do laser to destroy the vessels we can reach, and then potentially use a cream to knock down, any rebound or knock down the pathway a bit more. That really is still in development. And part of that is that the most common gene we see causing these port wine birthmarks, the GNAQ R183 variant, it's very difficult to figure out how it signals. We know a lot about the pathways that are quite downstream. We actually know a lot about how many other vascular anomalies signal, but this one has been tricky, in part because we know these are progressive. We understand the natural history, but being able to correlate that from a translational level on what is actually happening to the cells and why they get thicker, why we see overgrowth, why we see the development of vascular blebs has been a little bit out of reach, but I think we're getting closer. And so hopefully over the next 10 years, that will become a new reality, which will help all of our patients for whom we just, no matter what we try, we can't get more. And I do think there are some, novel thinking around how to set the laser, bigger spot sizes, maybe multi-passes, thinking about the way you set the pulse duration, potentially even imaging the vasculature, as Dr. Kelly has done. We've done a little bit of that also to think about how to more precisely set our parameters. Those are all studies in progress. But it's still a lot of guesswork, right? We look at the patient
Right.
and we think, where are these vessels? How deep are they? How big are they? And all of that sort of intuition guides how we set the laser. And then we watch the endpoints very carefully to make sure we're not getting too much damage in the skin. And I think it's a really tough problem. And hopefully we'll have more over the next 10 years.
Thank you for that. So Dr. Kelly, Shamal Shah wants to know, how do we treat eyebrows and under bottom eyelid area? Clearance has been very good for the entire face, other than those areas which are not treated at all.
So the eyebrow area is definitely tricky because there is the risk of losing the eyebrow hair. And it's a pretty significant risk. I mean, I've seen on platforms sometimes where people will say, well, the pulse dye laser won't remove hair. I can guarantee you it can remove hair. I mean, we have other devices, lasers that go deeper that are made for hair removal. But, definitely if you're treating over that area, and especially if there's brown or darker hair, then there is a likelihood that with multiple treatments, you will get permanent decrease in the hair. I've even seen it, for example, in like a young boy who we started treating as a very young child when they, of course, did not have beard hair or something. But as they get to become a teenager and their beard or mustache comes in where we've treated, they'll have decreased hair on that side. So it definitely can happen. It's difficult. People have suggested, Roy Geronimus, I want to proper credit, has suggested using lower energies and perhaps using something like ultrasound gel or something like that to try to protect the hair a little bit. I think that's a possibility. Probably there's pros and cons to that. I think there's still some risk to that, but it might be an option. So it is a difficult question. The same would be treating in the scalp. That's often why we don't treat in the scalp, because you can also decrease the hair there. From the under eyelid standpoint, which I think was also in the question, if you put a shield in, you should be able to treat under the eyelid quite well. And so sometimes there might be a little tiny area, but that isn't a time when, although I normally like to use bigger spot sizes for these treatments because we get more energy to the maximum depth. But sometimes if I'm going like right on an island, I want to go right up to the lid margin, I might use a smaller spot size, like 7 millimeters, just because the hand piece is sometimes a little bit easier just to get right up to that lid margin. So that can sometimes help. But usually we can get that. The advantage there is the skin is pretty thin in those areas, so the vessels are not particularly deep. So oftentimes we can get improvement there.
Yeah, it's just a shame that there are so many physicians that just are afraid to treat that whole area. So we get people coming to the conference with bullseye, and they're coming to get their first treatment with an eye shield. That was a great answer. So, Dr. Arkin, Daniela says, I am 58. I have had over 60 V-beam perfecta treatments on my facial port wine stain and have about 50% clearance. Do some doctors eventually stop treatment, or are they keeping the port wine stain healthy and from thickening by continuing to treat?
That is a fantastic question. I think, 20 years ago, we used to tell people these don't change, they're static, but the reality is they are not. They are very slowly progressive. And so there is always some maintenance involved. And when you think about the cause of these, which is actually a change in the genes that only affects the area of the birthmark. So the skin, if it's overlying the eyelids, sometimes the eye itself, and if it's overlying the forehead, sometimes not just skin, but skin and brain. That variant can't be picked up anywhere else. So we can't get it in the blood. We have to actually do a biopsy in order to prove the genetic cause. But that intrinsic sort of mechanism, the fact that these are genetic and that our lasers, really our pulse dye laser, is the safest of all of our treatments, in part because it really only gets you about 1 millimeter or 1.5 millimeters through the depth of the skin, and it's totally not specific for this genetic change. So it's not like it's looking for the vessels that have the GNAQ variant or whatever other variant is driving the birthmark. It's just taking out what it can reach. And it really is like the Goldilocks phenomenon, right? It has to be the right size vessel in the right location with the right amount of energy and all the right settings in order to photocoagulate or destroy the vessel that's there. And so we reach what we can, but we can't reach it all. And that is often why we talk so much about the need for maintenance, because these do sort of recrudesce, or you get sort of a rebound phenomenon where eventually over a slow period of time there probably is revascularization of the vessels around it, and the vessels with a genetic change that we can't reach are still signaling in the way they signal. And so I do think, like, it's not like we still do every single month for patients who are doing incredibly well. I think it's also one of the reasons, and Roy's work has been so instrumental in really changing the field. It's why we treat so early, because, infants have very thin skin. They have, probably the right size vessels. They can't be too big, they can't be too small, so we can intrinsically reach more of them with a laser. And in some ways, we really think of this as gene therapy. The light is not specific for the variant, but it's going to take everything it can reach. And we know the variant lives in the blood vessel. So if you have a privileged time where you can reach it, we try to get as much of it as we can. I think some of the new treatments, hopefully in the next, 10 or 15 years, will change the way we treat all of our patients, because obviously we can't go back, right? But it's partially why you always need some maintenance and why we push so hard to treat these very early on.
Thank you. That was great. Dr. Kelly, Karina says, hi, I'm currently receiving laser treatment for my port wine, and I developed some blebs that make me feel uncomfortable. Is there any treatments for bleb other than what you discussed?
Well, there aren't any medications or anything like that, as Dr. Arkin was just discussing, so I think the options are, I mean, I also sometimes you can double pulse with the pulse dye laser. And so, just when you're doing your pulse dye laser, you can do that. And honestly, quite honestly, for smaller nodules, I think that works fine. And then there's decreased risk compared to using the long pulsed Nd:YAG. There is the long pulsed Nd:YAG, or there's also the Alexandrite, the 755 nanometer laser, which goes deeper than the pulsed dye laser. So that's another option. Like I say, you can shave them. You can just do cautery itself. You can just, we
That's what I was
numb it
wondering.
up. Yeah. And so because it feels uncomfortable. I don't have a port wine birthmark, but I have had other things cauterized on me. And, so you feel a little bit of a electrical kind of feeling, but so you can numb it up so you don't feel that. And then they can just, use the little point cautery to do it. So, I mean, there are a lot of ways we can treat the nodules, and quite successfully most of the time.
Thank you for that. This is a question I've never seen, Dr. Arkin. So Nancy wants to know, would it be more appropriate to have treatment in the eye area if the eye is no longer viable? She has a prosthetic eye, so obviously she has stain over that eye.
Yeah. I mean, I think we all treat the eyelid because of the visibility of the stain involving the eyelid. But even with a prosthetic eye, even if you're blind in one eye, we absolutely need to protect the eye. We need to protect the prosthesis too, in part because, right, this is like light looking for blood turns into heat. That heat can cause damage where it's used. And so the way we do that and the way we keep patients comfortable is to numb the eye with a drop of either tetracaine or proparacaine. I tend to use proparacaine. It seems to not like you don't feel any sensation. It just feels like a drop of water. And then it's very easy to put in a corneal shield. It's literally just like a contact lens. We do it in these infants who start and come in at 2 to 3 weeks, and they do great. The adults are like, it's fine, whatever. I don't even feel it. So we absolutely would not withhold treating the eyelid, but we want to do it in the safest manner possible.
Thank you for that. So Marie is asking a direct question to you, Dr. Arkin. She said, you mentioned that the PW birthmarks are genetic. Aren't they de novo, not inherited?
That is a great question. I'm so glad you asked that. So, that is right. This is not an inherited phenomenon. If you have a child with a port wine birthmark, you did not give it to them. This is not a change that can be passed down in the blood. And in fact, if we do a blood test, just like we would check for other diseases that are affecting all cells in the body, you will not find this variant. So it's a very, very late change that happens during gestation. So when the mom is pregnant with the baby, it's not associated with anything that a woman has done wrong. There's nothing that we found that causes these. It's really just this random event. And when it happens much earlier, we see more widespread birthmark, and often not just skin, but skin, sometimes eye and brain, depending on the geography of the stain, but cannot be inherited. Your child or you with a port wine birthmark will absolutely not pass it on to your child, and their child will not pass it on to their children. all vascular anomalies are this sort of late stage genetic change in a field effect, and we call that mosaicism. We say, only affects a certain cell type within, a certain region, isn't affecting every cell in the body. And in fact, this variant, if it happens very, very early on, it's fatal because you can't survive if it affects, many, many cell types in the body.
That's interesting. I have a question for you because we had a family of 5 come to our conference last year, and all 5 of them had a CM-AVM.
Well, that is the one exception.
Okay, good.
So when you have a high flow stain or a fast flow stain, that means lots and lots of blood in it, and they actually look quite different.
Mhm.
They can be sort of a little bit stellate in their appearance. They can have sort of pale halos within them, or sometimes they just look like these round, almost cafe au lait spots that are ovoid and they're pink instead of brown. Those are often bilateral or, in many places on the body. And that fast flow stain is the clue to an inherited germline condition that predisposes to AVMs in the brain and spine. And those are inherited. So they are passed down with 50%. Sometimes they're de novo. So, as soon as I make a diagnosis, I'll test the whole family. Sometimes it's only one patient and not the others. And there are 2 genes that have been defined so far that capture this capillary malformation, arteriovenous malformation syndrome, and they are RASA-A1, which is our highest risk gene. And those patients, we 100% immediately screen their brain and spine because the skin is the tip of the iceberg. So they can have arteriovenous malformations anywhere along the neurologic axis. And the reason we MRI is when we find them, we can often treat them before anything happens. And then the second gene is called EPHB4. And that variant is actually probably very common. We have a lot of patients who have it. There's a significantly lower risk for AVMs, but they often have like telangiectasias on their face. They sometimes have nosebleeds. They can have these hypopigmented macules on the arms and legs called beer spots. And the capillary malformation looks a bit different. I think those actually respond pretty well to laser also, but it's really the do not miss diagnosis because we want to do an MRI of the brain and spine and make sure it's read at the right place to make sure we're not missing anything.
Thank you for that. This next question is a good one for you, Dr. Kelly. What is the average timeline for the birthmark to come back? If there is 75% clearance during infancy, is it a few months or is it 5 to 10 years?
That is a very good question. And honestly, I think it varies patient to patient. And why does it vary? That's a good question. We don't know. Could it possibly be that, the percent that have the gene change are different in different people? Maybe it's like 1% of the endothelial cells, the cells that line the blood vessels that have it in some patients, and could it be a higher percentage in other patients? That might be one reason why. There are patients, our hope is, if you get it early and clear the majority of it, it could be years. And the other thing I want to emphasize is about recurrence is that it pretty much never goes back to where you started. You get some recurrence, but it is quite rare for it to really go back to where you started. So you are going to have some prolonged benefit, but whether you get some recurrence, if there are any of the cells that have the gene change there's probably a reasonable chance that you would get some recurrence, but again, it won't go back to where you started. And this is again where we're kind of hoping, and I want to emphasize that we do not have medications yet, just like Dr. Arkin said, but our hope would be, if we got someone mostly clear early on, and then they were to apply a topical medication, might they be able to prolong the benefit and maybe not need a further course of treatment? But again, we don't have that yet, but that would be the hope for the future.
Would that possibly be something like an mTOR inhibitor? Would that be what they would be looking for topically?
Well, and Dr. Arkin should definitely chime in here, but Maybe, but I mean, there are mTOR inhibitors that are not that efficacious here, so probably not. It's very interesting, but we have created a really with Dr. Chris Hughes, we created like a model where we can screen drugs, so we take a little biopsy from a patient, and then we can make the blood vessels kind of in a little model, and then we can kind of screen medications to see which medications might be beneficial. And it is not all, some of the things that they've identified are not what you would have thought. So there probably going to be other medications that we can use, but again, I don't know for sure. And again, Dr. Arkin has a lot of information about this, so I'd love to hear her answer.
I mean, I actually think Dr. Kelly's microfluidics model, sort of combining patient samples and then an environment that recapitulates the normal skin, is totally the next generation for how we do drug screening. The animal models for this gene have been very challenging because if you turn the gene on in every cell, the mouse dies. And so you have to modulate how many cells are affected and see that the skin is affected. And we do have an animal model. It's been pretty slow going to be able to really understand the way this gene signals. We also, like Dr. Kelly, have a study ongoing to look at what's called spatial transcriptomics to try to understand across the lifespan, what signaling is occurring and how do we look at the way cells are signaling within skin samples themselves. And that work is very, very slow because unlike some of our other vascular anomalies, for example, venous malformations and lymphatic malformations, where we know that blocking mTOR will be effective because we know the gene, we know exactly how it signals. We can think about, topical medications, we can think about oral medications. The GNAQ gene has been very, very tricky to better understand exactly what's happening, how the cells are which pathways are being activated to even say there's a good rationale for why this drug would work. Somebody asked a question about gene therapy in animal models, and I do think there is possibility for some of the new gene editing and CRISPR technology to be helpful. That's work that is very high risk, potentially very high reward. The timing of that treatment would likely be very critical also. And so I know it's ongoing for many of these disorders like sickle cell and some of the other, germline disorders where you can deliver the protein, turn it on, and then have it be effective for the whole patient. I think we're a ways away from that for this condition. And part of that is, high risk means, potential a lot of risk for a condition that often just involves the skin. But I think it's very exciting work that will likely happen sort of on the cellular level in the lab before we go bench to bedside.
Thank you for that. So the next question is from Dr. Like G. I know him. He's from New York. The patient is 6 years old, has had multiple PDL therapy for port wine stain, and has responded well. What advantages do you see with the new laser? More comfort, more effectiveness, and any work on gene therapy you're aware of, maybe in animal models?
So I think with the new laser, again, using our bigger spot sizes, we can probably go a little bit faster. Our hope is that with the more even distribution of the light, even at short pulse durations, which seem to work the best, usually for the port wine birthmarks, that we might be able to get a slightly better result, maybe. I don't want to promise that, but maybe. And again, if we can move faster, it might be more comfortable for the patient in terms of, if you can get it done quicker, it might be more comfortable. Also, with the post-cooling, our hope is that may add some comfort for the patients. And so those are the advantages. Now, do I think we'll get dramatically better clearance? Probably not. Might we be able to do something that we do like a long pulse 532 laser where we use longer pulse duration so there's less bruising with the treatments? Maybe we'll be able to do something like that. And so although I don't think it'll change the amount of clearance. It might be that people wouldn't have so much bruising afterwards, maybe a little bit more swelling, but perhaps for some people who have to go to work or school afterwards, that might make it more comfortable for them.
Okay. This is a good question for both of you. Is there any treatment available today for the ear canal? My derm to who treats my port wine says no. As I mature, I'm 58, my ear canal is narrowing, which is causing some issues. So Dr. Kelly, what do you think?
I think that's interesting. I think now I mean you can, I mean, so I would definitely want you to see an ENT, ear, nose, and throat specialist or otolaryngologist to understand exactly what's happening. When you say it's narrowing, like where is it narrowing? You know what I mean? So like if it's more like the external ear canal, then I think you know, you might be able to treat a portion of it. If it's deeper down where we really can't get the laser, that would be more difficult. But then again, there might be other options for the otolaryngologist or ear, nose, and throat specialist to be able to help you with that. So I would definitely see a specialist who is going to be able to look down the canal, kind of determine exactly what is happening, and should be able to provide some treatment options.
Okay. Dr. Arkin, do you have anything to add to that?
Yeah, I totally agree. I have one patient who reports very similar findings, and I sent him to ENT, and they, you know, they have a lot of other options available. Obviously, some of this has to be done in the OR, but they sometimes use lasers that just ablate the tissue. Obviously, you have to control for bleeding, but um, it's really ENT that would be the sort of master of diagnostics and also any intervention that would help, particularly with like conductive hearing loss, which is what would happen if you really had narrowing in the area.
So, Daniela, you can feel free to email me at vbfpresident@gmail.com. Let me know where you live because I have quite a few ENTs that also have lasers, like Dr. Darrow is one of them, who may very well be the person you need to see so that they're an ENT and they also do laser, so they're going to know all the different options. So feel free to email me and I can get you a list of who those are in the US. The next one, so Nabil L. Hi, Kelly. So I guess they know you. We spoke over email a while back. I tried to sign up for your trial, but I'm all the way in Europe. Your new research gave me hope.
Yeah, so I think what they're talking about is we do have a trial for photodynamic therapy, and so it does involve you have to get like a intravenous medication, and then you really have to stay out of the sun for at least a couple of days, but really the labeling is for as long as 2 weeks. So it's very hard for people who are traveling to do that kind of thing, and then we need to do multiple follow-ups and things like that. So it's been difficult for people who don't live in our area to participate in that. I will tell you that there are multiple sites that are participating in this trial, so including ones in the Northeast. I think there's one in New York. There's definitely one in Miami and that UC Irvine. So there are multiple places, but you kind of have to be in those areas. But I do think there's potential with this treatment, but I think and the nose, you know, there's also risk with this treatment. Again, it's not only the protecting yourself from the sun, but with these treatments, there is a risk that you could get blisters that could result in a mark or scarring. Right now, we're evaluating just areas on the extremities and behind the neck and kind of small areas. But as treatments are done with this approach, photodynamic therapy in China, and it has been done that way for over 10 years. And so that is another option.
Thank you for that. Dr. Arkin, Katie says, my baby has a large hemangioma on her thigh. It's now flat. She's 9 months old. No more shrinkage or change. The GP wants to start the propranolol at 1 as it's not doing anything else now. Could it grow back once we stop? And maybe you could address actually adding laser to that.
Yeah. So I think the question is your GP wants to stop propranolol at 1, not start it at 1. Okay.
Right.
Yes, I would absolutely add a little bit of laser here. What we know about propranolol is that it's enormously helpful and effective in treating infantile hemangiomas, which are really different from port wine birthmarks. So they are vascular tumors. They present usually somewhere in the first couple of weeks of life. They go through a period where they really grow quickly in this phase they call the proliferative phase. They stabilize sometimes between 4 and 6 months, and then there's a very, very slow period of involution that happens at 12 months. Propranolol expedites all of that, and we still, in truth, don't really understand how it works, but it's been FDA approved for 12 years now, and it's absolutely our first line standard of care. It is very effective at treating the deeper component in the infantile hemangioma as you've reported. So it's great at making it flat. It's not that good at expediting resolution of the surface vascularity. And you think about it like it's a medication that, it's going through your body. It's got a first pass through your liver. It's coming from the blood out. So often we'll combine laser treatment with the beta blocker. I would say, especially in very visible areas where you're not getting a lot of response in the superficial component, we often start that pretty early. One treatment is not usually enough. I would say if I'm doing more than one for like a large segmental lesion, it's maybe 3, 4 max. They respond beautifully. You do need to have somebody who really knows what they're doing if they're starting early. I think 9 months where you've had treatment effect is probably very low risk. So it would be a great idea to add it. If the hemangioma is mostly flat and you add some laser and you get a lot of lightening, it's very unlikely that after a year you see a lot of rebound, but sometimes we do see rebound. And I'll tell you, 12 years ago, I was taking everyone off at 12 months, and then I had a bunch of kids who it really rebounded, and I've started extending it just a bit longer if they're doing really well. If, I laser and there's like nothing left, 12 months is perfect. And I think a lot of the published studies have actually shown that if you add laser, the outcomes are excellent. It's very, very safe. Roy published a retrospective study showing you could actually, reduce the duration of propranolol treatment. These hemangiomas they're pretty heterogeneous, like they're not all the same. And so if you have a really superficial lesion, they respond quickly. If you have something deeper or larger, I think you need a bit longer. But I would say most of the time I'm taking kids off between 13 and 14 months, and they very rarely rebound if you have a really good result at that time.
Thank you for that. A follow-up question for you, Dr. Kelly, from Nabil. He was asking about the PDT, and he said, I have a port wine stain on my right hand that goes all the way up my arm to my chest. Realistically, how do you think this new direction of treatment could help?
Well, I think it's this treatment, for example, in China, they do it not only in those areas. In the study, they decide to start with extremity lesions and the ones behind the neck, but it wouldn't be only those patients eventually who might be eligible, but for the study, that is the case. The hope is that it will give a better result for some patients. Now, I think that laser I think laser, like the pulse dye laser, is a safer option. So for the majority of people, I think that's still the best options. But for people who have resistant lesions, there is some literature that shows that some people can get a good result with photodynamic therapy. So that might be an option. Also, an important thing to keep in mind is sometimes when patient has a darker skin type, then it can be very difficult to treat with the laser. And the main reason is because the laser has to pass through the surface of the skin where the melanin, which gives us our color of our skin, is, and some of the light gets absorbed there. And so you are limited when there's more of the pigment there as to what energy you can use. So for patients who have significantly darker skin, it can be very difficult to get a good result with the laser. Now, I do think that starting early helps that. Another good reason to start really early in patients because there's less melanin when someone's very young. And so that gives another advantage to starting very early. But photodynamic therapy is another option because it does not depend on light getting through the melanin. The light, it's reactive oxygen species that are formed with the combination of the medicine and the light. So it's a different mechanism. So it might give us an option for patients with darker skin.
Thank you for that. Dr. Arkin, this question's for you. Jennifer is asking you, is it possible that the genetic mutation happened during gestation to cause the port wine stain was something that the mother did, which I know you said before was not, or something in the environment that caused it?
That is a great question. I think definitively we can say nothing that the mother did. Environmental influences are enormously difficult to disentangle, right? Um, and we don't think it's a medication exposure, like we don't think it's anything that the mom did, but there's likely some association that could be found. I don't think any of the data to date supports that we can identify an environmental cause, and 100% not something the mom did. This is really just a random thing. Like, it's not, we think about, some of the rates of trisomy 21 being elevated in mothers who have babies late after age 35. This 100%, we have not seen this. Like, I think it would be pure speculation to assume there could be an environmental trigger, and those are always the hardest studies to try to suss out because associations don't mean causation. And so I would tell you to both of those at this point, no.
Thank you for that. Dr. Kelly, Maria says, my son is 14 and started treatments as an infant. He had 2 to 3 treatments a year the earlier years, and then about once a year as an adolescent. We're seeing much less clearance these last few years and wondering if hormones play a role. He had a treatment last year, not under anesthesia. Ouch. And the lightness lasted for a few months, and now it looks the same or even darker. Any thoughts? It really also does seem like an art and always looking for new ideas on settings, spot sizes, laser types, etc.
Excellent question. And you make several potential points that we can make from your question. One is often when I do, when someone gets some recurrence and we are doing treatments again, I often do a series of treatments and I still do it, 3 to 5 weeks apart, depending on how soon someone can come on for a follow-up. Now, again, they've been talking about weekly treatment or maybe even daily very early on. In adults, that's hard to do because, or teens, it's harder to do because they get more purpura or bruising, right? And so you can't treat like every day, but you can treat every 3 to 4 weeks for the most part, unless someone gets some discoloration in the skin because of treatment. And so I often find that I'll do a series of treatments like that, and I'll get a little bit more benefit from doing a series close together. Keep in mind, and Dr. Arkin mentioned this, that, we've done some studies in a variety of models that do show that even as soon as like a week, some of those vessels start to regrow. And there are even times when the vessels regrow that you actually get more vessels. I want to be very clear. This is not indicating that laser causes worsening, because it is true that depending on where those vessels are, it might appear darker, et cetera, because just as you remove some the vessels on the surface and you have someone underneath, sometimes they look a little bit different, et cetera. So this being said, I think perhaps doing, a series of treatments might be helpful. And then there might be different things. You could try the different wavelengths, like the long pulse 532 for some people can have some benefit. Perhaps doing multiple passes. Dr. Arkin mentioned that. So that's another thing that we sometimes do. So I think there are a variety of things that could be done to potentially help.
Thank you for that. Dr. Arkin, Caitlin says, my son is 8 months old, born with a port wine birthmark from his lower spine extending down to his right great toe. The color changes and is more of a mottled appearance. We have recently learned that he is PIK3CA positive. Would laser benefit him in the long run, or would this be more cosmetic?
Well, that's a great question. I mean, I guess Dr. Kelly and I would say these are vascular anomalies that are genetic. None of what we do is cosmetic, it's more restorative. I think the PIK3CA variants that are non-hotspot are quite interesting because sometimes in the first year or so they do lighten a little bit. I think they respond beautifully to early laser. Like, on the face, we can really make them go away. Obviously, not every capillary malformation with PIK3CA is the same. I also think having the genetic change helps you a lot, because there are drugs available that inhibit that pathway, not really to be used for skin. And I'll tell you, like, we probably have 30 or 40 kids with the same variant. Um, some of them are on either sirolimus or, more recently, over the last 3 years, a drug called alpelisib, which directly inhibits the PI3C kinase pathway. The question is always like, balancing the risk and the benefit in a young baby. And so if your infant is doing very well and it's really just skin and maybe a little bit of overgrowth, which we see commonly in patients who have this PIK3CA related overgrowth, then probably we would not use the drug, but it helps us to know what the pathway is, because in the next, there are now next generations of PIK3CA inhibitors in clinical trials, and in 5 years there will be more, and eventually there might even be a topical cream, because that's a pathway we've interrogated very well. So we know how it signals, we know how to inhibit it. But I would tell you, don't be afraid of laser. Now, if you're gonna start, I'd probably do it soon, because lasering, of 16, 17, 18, 19, 20-month old is very difficult in the office. 8 months probably should be okay. I actually don't think you need a lot of energy for those kind of light pink reticulated birthmarks that are non-hotspot. But it's a very personal decision. I think, particularly when they're off the face, right? And I think PIK3CA, we see more overgrowth of the soft tissue, less sort of profound progression or darkening of the skin. We do sometimes see these second hits, which can create pyogenic granulomas or other vascular tumors. But I certainly would not balk from doing laser. I think they respond quite well, and I'd love to hear Dr. Kelly's thoughts.
I think that's a good point. I mean, honestly, each person, when it's someone who's old enough to make make a decision for themselves, or each family, when it's a child, has to decide. I think, again, there are some clear advantages to treating early. So I think many people choose to go that route, but it's not the right answer for everyone. So an individual decision.
Thank you. And Dr. Kelly, Carissa wants to know, can someone tell me if it's okay to do the KTP laser instead of the V-beam? I'm being treated at the University of Chicago and she's using the KTP. Should I switch?
So KTP stands for potassium titanyl phosphate. It's just like a different crystal that is used for to make the laser light. And it's remember I mentioned the long pulse 532. It's just another name for the long pulse 532. So it can be called KTP, long pulse 532, same thing. And I think it's a perfectly reasonable option. We have a study that is being reviewed for publication, and Katharina Herberger in Germany also did a publication looking at long pulse 532 versus the pulse dye laser. I think hers were mostly port wine birthmarks. Ours was in multiple vascular conditions. And honestly, we could achieve, I could not tell, except unless I knew in the patient which area we had treated with the long pulse 532 and which area we had treated with the pulse dye laser. We could get equivalent results.
Wow, that's amazing. Hi, Allie. So Allie Pedrick has a great question for you, Lisa, Dr. Arkin. My son is 2 years old. He has a slow flow vascular anomaly with eruptive pyogenic granulomas. They've identified not GNAQ mutation, but BRAF V600E mutation, 14% allele fraction. Have you seen this before? He's found good success on oral trametinib to hold off new PGs. What are your thoughts on beginning laser again? His team is wondering if that's our next step now that the PGs seem under control, or is it likely the vessels would regrow rapidly?
So my question is always, was the PG sent for analysis to find the BRAF, or the PG and the stain together? Because more commonly we actually find like one variant in the capillary malformation and then a second hit into the PG, because these vascular tumors that are erupting, they usually are kind of acquisition of additional mutations that drives the growth. BRAF is a variant. We actually have a couple of kids with vascular anomalies who are BRAF positive. We also have many, many PGs on top of a capillary malformation that are BRAF positive. And it's really challenging when they are eruptive because they bleed, they're, incredibly difficult. Even when you excise them, they can recur. Like they really behave like arteriovenous malformations. And on the BRAF pathway, trametinib is a very appropriate target because it's down, like trametinib is a MEK inhibitor. It's downstream of BRAF. It's a tough drug because there are a lot of side effects in older kids. So we see a lot of acneiform eruptions and other skin side effects. We actually have a lot of patients with variants on that pathway with arteriovenous malformations who are either on trametinib or its cousin drug, selumetinib. And I would say, if it is a capillary malformation, it would be fine to laser on trametinib. We worry a little bit about wound healing, and so often we'll, stop it 2 days before and then restart as they're healing. I'm very thoughtful and careful about energy in those patients, and I think, having a little bit more information about whether the whole thing is BRAF or there's a second hit in BRAF with a VAF of 14 would probably help me. And I do think, these are not all the same, even when they're BRAF, even when they're the same variant. I mean, we think about our port wine birthmarks, they're 95% GNAQ R183, and yet the forehead responds so differently from the medial cheek, which responds so differently than the dorsal hand. They're all the same variant. It's just really about, sometimes gravity, how thick the skin is, how big the vessels are, where the vessels are. So I think I need just a little more data to help you, but I wouldn't shy away from treating on trametinib.
Thank you for that. So Dr. Kelly, Erica wants to know who's a candidate for the new PDT treatment, what age, and who is doing it in New York?
So again, this is a study. And so currently it is 18 and above, and I think they just raised the oldest age. So I think it was 65. I believe it's now 70. I don't want to misquote you, but I think that is correct. And then right now it is lesions that are on extremities or behind kind of the back of the neck or behind the ear. So those are the locations that we're studying right now. And I am not 100% who is participating at the other centers, but if you want to send me a message, I'd be happy to clarify and find out if there's someone in your area.
Okay. And you can email me at vbfpresident@gmail.com, and I can give you Dr. Kelly's email, or you can email her through the VBF Ask the Expert portal. Dr. Arkin, Valagal asks, are the PDT trials in the U.S. sites you mentioned open for enrollment now? Miami, California, New York, or maybe that's for you, Dr. Kelly.
Yeah, I think it's Andrew Krukowski in Pennsylvania, who's the third, right?
I think actually there's more than three. I think there's multiple sites. And so,
Right.
and the reason I hesitate is I'm not sure who is, there was one in New York. I'm not sure if they're still participating in the study or not. So that's why I'm not 100% certain, but I could definitely clarify that. Yes, I mean, definitely we are still enrolling. And I know for sure that Miami and California and Southern California are currently enrolling, and I could clarify the other sites.
The one way, just for the group to look at clinical trials that are open for enrollment is to go to the website clinicaltrials.gov. And then if you enter port wine, birthmark, and photodynamic therapy, it'll give you most of the trial protocol and all the actively recruiting sites. So that could be a good start.
Thank you.
Well, we're almost wrapping up, but this is a good one, Marie, and I can answer this. She said, thank you for your expertise and care, everyone. Linda, your work has been life-changing for so many. Thank you, and being at the forefront of this condition. I would love to see us adopt the term port wine birthmark versus stain that many feel has a negative connotation, PWB versus PWS. And we did a study of 843 adults, and we asked many questions. The most interesting thing was it was almost identical. It was 33, 31, 31 on who loves it, who hates it, and who just accepts it. Those were the choices. And then we asked about port wine stain versus port wine birthmark, and almost 70% said they didn't care which one it was. And about 20% said they did care. And so the other thing is, we haven't completely dropped the word stain because of all the research that has it. And there are 19 capillary malformation slash port wine stain slash port wine birthmark slash, fire mark groups from all around the world. And they still use that old terminology, or that terminology, port wine stain. So just like the old lymphangioma, cystic hygroma, lymphatic malformation, I still keep those terms active because there are groups that keep those terms active. So I understand what you're saying, Marie, and there are people that don't like it, but there are a lot of people that are indifferent and some like it. I don't know what else to tell you, but it's an individual thing. And I don't know if either of you have experience in that with, what it's referred to. Have you ever had that, Dr. Arkin?
Yeah, I think the whole terminology and classification for vascular anomalies is just unbelievably confusing. And the classification so far has relied on like what it looks like radiologically, what it looks like clinically, and then any associated findings that make it a syndrome. And the reality is, like in the next generation of genetic testing, where we say this is a BRAF PG on a GNAC stain, we're probably going to get a little bit better integration. But I agree. I think the word stain has negative connotation, and we kind of relieve that by using the term birthmark. And I think Dr. Kelly and I mostly will use the term port wine capillary malformation or port wine capillary birthmark. Um, it is a little confusing that there are these capillary malformations that are associated with CM-AVM syndrome, and they're really different from the typical kind of port wine birthmarks we see. And hopefully in the next, I don't know, 5 to 10 years, we'll get a little better clarity on kind of what to call things. But I'm with you. I think using the word stain to identify a person just doesn't feel good. It's not right. This is, a genetic birthmark. It's not environmental. It's not a stain on them. And we really want to normalize that vernacular.
That's a good point. Because we only have 1 minute left. Dr. Kelly, Shannon Verheis wants to know, she says she's 54 and has had 12 pulse dye treatments on her large facial port wine. At this point, looking to avoid cobblestoning. What's the best course of action for me?
So that's a good question. And then the question is, will continued treatments help to minimize that? I think that there is at least the potential that it would. So I think, at least following up with someone who has the potential of giving you the laser treatments, perhaps doing some maintenance treatments may help. Can I promise you 100% that that won't prevent some thickening or cobblestoning? No, but I think that there's a reasonable chance that it could help.
Thank you. And you know what, Dr. Arkin, you're going to want to answer this question. How do you tell if it's a PWS versus an infantile hemangioma?
Well, that is a great question because they can be mimics early on, particularly in the early proliferative phase, but there are some critical differences. The infantile hemangiomas are fast flow, so they have a lot of blood. They tend to be more bright red, or sometimes they look pink early on with these tiny little reticular sort of blue vessels running down them. And then if you wait 2 weeks, they're bright red and they're changing. I think most of the time our dermatologists are able to make this diagnosis, but it can be a little bit confusing. But the real hallmark that distinguishes them is that infantile hemangiomas are rapidly changing. They grow, they are tumors, they are not static. And port wine birthmarks as vascular malformations are not static, but they change very, very slowly over the course of, 35, 45 years. And so that chronicity in the natural history helps you as well.
I usually tell them they can tell by about the third or fourth week because the
Yes.
hemangiomas get really angry
Yes.
and the port wine is just kind of still there,
Got it.
So, what a great session, ladies, especially for our month of awareness. And today is when you put on your birthmark. I forgot to put my red heart on my face, but I've been seeing on social media all day long red hearts. So, thank you, everybody, for helping us to raise awareness because awareness is what brings change. And I'd like to thank you both for your time. And anyone who wants to rewatch this, it will be on our Facebook page for the next 30 days. Then it will live indefinitely on our YouTube channel, and you can go back and rewatch it because I know I've seen some of you already write in here. How can you see this again? So it'll be on our Facebook page for the next 30 days. And then on the front of our website at birthmark.org, you'll see the YouTube logo icon and then click on it and you'll see all of every Facebook Live we've done back to 2017. And they have the names of the physicians and the dates that they were held so you can easily find it. So thank you both for your time. And I look forward to seeing you again at the next meeting. Take
Thank
care.
you.
Thank you both.
Bye,
And thank you for all
guys.
you've done. Thank
Have a
you.
good weekend.
Bye.
Thanks, Dr.